starts. Okay, now we are recording. Uh, so effective symptom management starts by listening to the patients, not just the lab results. And clinicians and doctors and nurses should prioritize the symptoms that patients themselves identify as most uh, trouble to them daily lives. So we are not just focusing the numerical lab values. Instead, we are more focusing on patients' perceptions. So what patients might experience, except what the lab reports tells you. So different patients can experience various symptoms from the nervous pain to the itching and dry skin and the nausea and sickness. So here is a paradigm shift. So even if this means that patients are tolerating less than ideal lab results, so which means like patients might receive bad results after receiving hemoabsorption or hemodialysis, but it doesn't necessarily mean that they are not achieving better outcomes because their perception of symptoms are improving. They are not feeling more itchy, or they are not feeling more troublesome by poor appetite or sleeping disorders, which means their quality of life actually improved after receiving hemoabsorption combined with hemodialysis. So I think this is what most important to the patients because we need to focus on how they feel and what we can give them. So this is why we need to focus on modern hemodialysis. So we need to look at other methods, including the high flex hemodialysis and hemoabsorption. So hemoabsorption is also an extracorporeal blood purification technique, which blood is passed through a cartridge containing absorbent materials that selectively remove toxin substance, such as cytokines and inflammatory mediators or endotoxins. So how we achieve that? We achieve that by binding them directly to the surface of the absorbent. So hemoabsorption is merely targeting the protein bound substance as well as middle to large molecule size substance that is harmful for the patients, including the beta 2 microglobin, uh, um, the myoglobin, and also the interleukin 6, the TNF alpha, and also the prolactin. So those are the proteins that we don't want them to accumulate in patients' body, in patients' blood. So let me introduce the new concept that has been invited by Jeffra, which is combined artificial kidney. So a combined artificial kidney is a concept which means that patient receive both dialysis and hemoabsorption treatment. They have different jobs. So dialysis removes small uremic toxins and balance the fluid levels, which means that dialysis keep patients alive. Meanwhile, hemoabsorption focus on remove middle to large uremic toxins and protein-bounded uremic toxins like beta 2 microglobin and IPTH. So one is to keep patient alive, the other one is to improve patient's life quality. So therefore, we are introducing our new solution, HA130. HA130 is a double cross-link styrene divinylbenzene copolymer as the absorbent. So it contains It contains mass pores with a large surface enable high efficiency in remove toxins. So it use three characters like hydrophobicity, van der Waals interaction, and also the molecule sieves. So the pulse also our advantages, including the pulse size adjustments. So we are using the nanoscopes pulse size adjustment techniques. So we have a big pole, we have a medium pole, and we have a small pole inside of our cartridge. And these three different pulses are targeting to different toxins, and we have a specific surface area and pole size and pole values to targeting the toxins. So if we have medium toxins go through the cartridge, so we have a medium pole size to trap the toxins inside of the cartridge. And also we are using the double crosslink. So the double crosslink is identify the high and rising structure is apparently more stable and the strength is better and the risk of partial falling off is smaller according to our research. And also we are having a advanced coating technology, so which means that we are not doing harm to the good or to the molecules that we want to stay in the body, like red blood cells, white blood cells, and also the albumin that we are not targeting to those good cells because we have coating materials, special coating materials. So this is a table just summarize the overall features and advantages and benefits of HA130. So HA130 has a plus almost more than 20 years of clinical applications, and it has been applied in almost like more than 90 countries and more than 5 million cases per year. So, and also we are having a EU MDR certification, means that we are able to sell the products and patient can use the products lawfully in the Europe countries. And this is just the specifications for the HA130 cartridge. So we have total cartridge volume 230 milliliters. We have priming values of total 100 millimeters, and the rising volume of is 130 millimeters. So let's move on to how to select the right patients. So patient selection is crucial. Each patient presents with their unique symptoms, making it essential to tailor treatment modalities and frequency based on their individual clinical manifestations. So some patients might present with shortness of breath. Some patients might present with itchy legs, or even some patients might present poor appetite or poor sleeping. So different patients might experiencing the different symptoms. As a healthcare professional, we need to acknowledge that patients' perceptions on their symptoms. And this is why that we need to focusing on the uh, 9 major complications. Here is a short videos introducing the 9 major complications that CKD patients are often experiencing. Sorry. Sorry, there is no sound. Um, Let me see. If let me re include.
Hello everyone, I'm Fan
Can
Xiaobao.
you hear the sound
Today
now?
we're going to explore the dialysis-related complications that often trouble patients undergoing maintenance hemodialysis, MHD. Hemodialysis primarily removes small molecule toxins. However, it has difficulty.
Sorry.
Hello everyone, I'm Fan Xiaobao. Today we're going to explore the dialysis-related complications that often trouble patients undergoing maintenance hemodialysis, MHD. Hemodialysis primarily removes small molecule toxins. However, it has difficulties in clearing medium and large molecule toxins, as well as protein-bound toxins. These toxins gradually accumulate in the body, leading to dialysis-related complications. So what exactly are these dialysis complications? Let's find out together. Uremic pruritus. It is extremely common and can be unbearably itchy when it occurs frequently. Secondary hyperparathyroidism. This condition can lead to bone pain, fractures, skeletal deformities, a decrease in height, and facial changes. Refractory hypertension. It's challenging to control even with combined medications, and vascular problems are prone to occur. Protein energy wasting. This results in muscle atrophy, weight loss, poor appetite, and constant fatigue. Restless leg syndrome. It feels as if ants are crawling on the legs, making it impossible to sit or stand comfortably and causing distress that affects both sleep and appetite. Uremia-related sleep disorders. Patients experience restlessness, difficulty falling asleep, frequent awakenings, vivid dreams, and overall fatigue. Uremic hyper-beta-2 microglobulinemia, which leads to amyloidosis and then affects joints, causing wrist canal pain and hand numbness. Uremic peripheral neuropathy. It leads to limb weakness or paralysis, causing a gradual loss of motor function. Microinflammatory states. It contributes to a variety of complications, such as arteriosclerosis and anemia. These complications severely impact both physical and mental health. So, how can we manage and avoid these complications? Here's a tip for you. That is, by using hemoadsorption. Hemoadsorption utilizes the principle of adsorption to remove medium and large molecule toxins, as well as protein-bound toxins from the bloodstream, effectively treating and preventing dialysis-related complications. Clinically, hemoadsorption is mainly used in combination with hemodialysis, which is known as the combined artificial kidney, HA plus HD. The combination of the two methods enables more thorough toxin clearance, prevents dialysis complications, and improves the quality of life for MHD patients. That's all for today. If you like me, don't forget to subscribe to our channel to get more insights. Thank you.
Okay. So this is just a short video that introduces you the 9 common major complications that we identify from years in patients who receive hemodialysis. So these 9 major complications that we experiencing can contribute to three major different reasons. So the first one is direct tissue damage from the uremic toxins. So if patients were having chronic kidney disease or kidney failures, their uremic toxins are accumulated in their blood and in their body. So these uremic toxins are directly damaging the tissues and the vessels and even the cells inside of patients' blood and causing patients are feeling itchy and feeling a little bit neural pain and also feeling that they have joint and tissues pains. So these three complications can are attributing to the direct tissue damage from the uremic toxins. So the next three complications are mainly caused by toxin-mediated metabolic distribution. So this is can cause that patients have protein energy wasting and micro-inflammatory stage. Patients with these three complications are often experiencing the poor appetite or the weight loss because they are suffering from the micro-inflammatory stage, which they cannot eat much food or they are not feeling like they want to eat more food, which causing that there is a huge protein loss in their body and further leading to the loss of muscle and loss of tissue cells. And the last three major complications can be caused by the neurovascular disease and sleeping disorder, which including the RLS, which is restless legs syndrome. So this is so the etiology of these complications is remain unknown, but according to the research and according to the clinicians' clinical experience, this is most likely caused by the uremic toxins accumulated in the patient's blood, which might worsen the sensory symptoms and disrupt sleeping. And patients with restless leg syndromes often have uremia-associated sleeping disorders because patients are feeling itching in their legs and which they cannot sleep in the night. So for the nine major complications, we have suggested frequencies. So for patients with uncommon symptoms, not like they have nine major complications, we recommended they use one session per week, so as a routine treatment. But however, for patients who are experiencing like nine major complications, we are recommending that they can use 2 to 3 sessions per week combined with hemodialysis. So for each sessions of hemoabsorption, we are recommending 4 hours for each sessions. And for the blood flow rate, we are ranging from 200 to 450 according to patients' individual circumstances and according to clinician's decision. So for anticoagulations, we are recommending the low molecular weight heparin and unfractionated heparin. And other anticoagulants also can be used, but we are just not recommending any doses because it's up to the doctor's decision. So this is the hospitals and institutions that have already utilized our products in the areas of CKD related treatment or research. As you can see, it is in Switzerland, in Greece, in Singapore, in Russia, and in Italy, and in Portugal. So this has been used widely around the world. So for the take-home message, uh, after all, besides of all the numerical lab results, we need to more focusing on patient's reception, and we need to more focusing on patient's symptoms individually. And the combined artificial kidney is effectively remove the macro molecule size and the protein bound toxins in the MHD patients, and patients with receive hemoabsorption technologies receive a better outcome. So this is just the Professor Mario who use our products. He says that we should focus on individualized treatment plan and good quality of life for patients. And that's all for the HA130. So if you have any questions, you can ask me or you can ask Eric.
Yes, this is HA130, today's training. So Patrick, he introduced our product in some general aspect. And then I think if you have any question, we can Q&A now, or we can start another part for ICU. What do you think? Shall we start in next session, or we can Q&A now?
Mr. Lai,
Yeah,
can everyone is everyone okay with this training? Any question for HA130?
yeah, Eric, I just want to ask you, so okay, for like normal HD, we are doing with about 4 hours, ma. So this HA130 also same hours with the dialysis or what?
Yes, same hours, same hours.
That means the absorption will last for 4 hours.
Absorption, actually, we take some tests. The maximum, I mean the peak. We see the curve, and then we last for 3 to 4 hours.
Okay.
So normally we start beginning with dialysis, can be off dialysis. So 可以一起结束。
Yeah, because it's better we can start and end with the same time, no? Yeah, because
Yes.
if not intermediate, we need to remove out the filter, then we got the double work because we need to return the blood to the patient, this and that. Yeah, then some what do you call blood loss. Yeah. So 4 hours. Okay. All right. So only priming, we understand this one. Okay.
Yes, more easier for the nursing. For overseas, we all together with the dialysis, but in China, we only do 2.5 hours because sometimes depends on the hospital. Yeah,
I think that we are follow maybe 4 hours is better.
Yes.
Easier. Yeah. Okay. And then let's say if we're using slide now, so because normally slide is more than 4 hours. How about that?
Okay, good question. Normally, according to our IFU, our suggested time is 2 to 12 hours. 12 hours. So if you can up to 12 hours, no problems. So our technology is absorption. So the toxin will absorb inside. So sometimes the doctor will ask, oh, how about if the time is longer than 4 hours, maybe the toxin will release? No, we will not, because we absorb it. And then even the blood or saline go into and flush the toxin, we will not go outside again.
Okay. Yep.
Because sometimes the doctor, they are busy. Just connect with the dialysis after the treatment finish. No problem.
Okay.
I think
Any
this
other
is
questions?
our basic selling points with HA130. I think HA130, from our experience in China, also from overseas, I think the first step, maybe our first objective is improve the patient life quality. The first objective. Another one. So if we understand this product is for the high-end people, I think that the beginning of the market, high-end people to improve their life quality. So how could we find the people who can afford this? Another one, we can go to the hospital, select some patient who have some significant symptom like itching. I mean the pruritus, 皮肤瘙痒, or hypertension, or they have some hormone problem, PTH, some problem. So we can find some significant symptom. Just let them try. So let them try. We can combine some commercial policy. After they try it in 1 month, they can feel some improvement. So they have their own willing to pay out their pocket to buy it. So I think this is my experience in Indonesia. Even Indonesia, the buy power is not very high, but we at the beginning of the promotion, we find at least one hospital, we find 2 to 5 patients. We cannot only find one, because why? Some patient after they use 1 month, they cannot feel anything. Maybe if we find 2, the percentage will be increased. 1 patient fail, at least we have 1 patient succeed. So at least we find 2 to 5 patients. So after they try, they will have the positive feedback. They will keep doing our product. So I think that's my suggestion for this product. I think for the connection, or we just need one extension tubing, is very easy. Before the dialyzer, connect with the dialyzer, that can prevent the clotting, because normally the clotting will happen in dialyzer. So we put the cartridge before the dialyzer. Also, we also can put behind the dialyzer, no problem. But we put in before the dialyzer, it will be better. Okay.
So the procedure is the HA130 is before the dialyzer or after the dialyzer?
Before. Our suggestion is before.
Okay.
Or you can put after, no problem.
Which one is more suitable?
Before
Before is better lah. Okay.
Yes.
We don't have any problem. So we will follow the SOP lah. Okay. So the
Yes.
instruction from recommendation by Jeffron. Okay.
Yes.
So
before just protect the dialyzer. Or protect.
Okay, so you see, because we need to do priming. Okay, so we need to connect the dialyzer. So that means the HA130 we need to separate priming, right?
No need to separate.
No need to separate. So we can do it together.
Yes.
Then how about how many how many unit of the heparin we need to flush to the HA130?
2 liters, right, Patrick? 2 liters for priming.
2 liter priming. How many ml for the heparin?
Yeah,
just Patrick, you can answer.
Yes. So if we are priming together with the dialyzer, I think we need to use a total 2.5 liters normal saline.
Okay.
And also 12,000 unit of heparin.
12,000 unit. Okay.
Heparin, yeah. So this is minimum doses that we use to prime the cartridge.
Okay.
How much priming volume? Sorry, I mean the volume of the HF 100. This 130.
So for priming the cartridge alone, we need to use at least 2 liters of 0.9% normal saline. But if we prime together with the dialyzer, we need to use at least 2.5 liter to 3 liter normal
Okay.
saline. Yes. So
Just now you mentioned the 2.5 liter is the 12,000 IU heparin is in 1 liter or in 2.5 liter?
so just in 1 liter.
Oh, okay. That is per liter lah. The 12,000 IU in 1 liter.
Yeah.
Okay.
In some clinical settings or nurses also sometimes they prime separately because sometimes they prime the cartridge first and they were doing the tubing connection on the
Before start
dialysis
patient, right?
machine, and yeah, and they can do it separately. But if we are priming together on the machine, you need to always you need to change the bag and change the parameters on the machine.
Oh, so means if they want to prime together, they need to change the setting. That's why they choose to prime separately.
Yeah, so you have to select like 1 liter on the machine, right? And once the nurse put on the normal saline and put on all the cartridge and dialyzer on the machine, they can start priming for 1 liter and they can doing other things. And once the 1 liter is flushing out, the machine will beeping and they need to come back and change another 1 liter to change the parameter and then they have to change everything. So it's a little more complicated than priming separately.
Oh, okay, understood.
Yeah. But
So
in China, okay.
okay. Sorry, just want to ask the cartridge itself is how many mil? Means it's what 2 liter is it? Or because when they drag the blood out, is a lot of blood to use for the extra corporeal
Yes,
iron.
so the total volume of the cartridge is 230 milliliter, the total cartridge volume, and the absorbent volume is 130, and the priming volume is 100.
Oh, okay.
Yeah, and the tubing volume I think is around 50 to 80 millimeters of the tubing volume. It depends on the different tubings.
Mm-hmm.
You're talking about the bird line?
Yeah.
Bird line usually is about 100,
75.
around 100 something, yeah.
Yeah,
So,
yeah.
75 to
yeah, around 100
100.
something, yes.
So
But
it
then,
depends on different tubings because we have our own tubings around 80 milliliters, but other
Okay,
tubings
so
might have been longer. So,
I think total is 200, about 230 lah, just now you mentioned.
yeah,
The
it's
blood
the
volume.
total volume, including the priming volume plus the absorbent volume. But the priming volume is only 100.
For the cartridge itself lah, you know.
Yeah, for the cartridge. Yeah. And
But I
another
think HD type patient is still fine. If it's ICU patient, that will be very depends on the condition.
sorry, can you repeat it?
What I mean is this volume I think is still fine for HD patient, but for ICU patient I think it's have to depends on their condition, right? Their BP.
Yes, but actually, because for the ICU we are using HA380, which is larger cartridge compared to the HA130, and the larger one that we are utilizing in the ICU settings. So ICU patients often are receiving CRRT treatment.
Yes, correct. Oh,
Yeah.
okay. So
So-
it's suppose it's 380 HA380.
Yeah, this
Yeah,
one is
so
HA130 is more suitable for HD, HDF, and SLAC. Okay, this is we are targeting. Okay, so the other 380 is the next section. Oh, waiting.
Okay.
yeah, yes.
Okay.
Okay,
Get it.
so we finish 130 first. Any question on 130?
That's all.
Yeah,
Can please check the
think-
chat? Check the chat.
Okay, do we have the tumors from the flesh?
Any other questions?
Yes, we have the documents for details for priming, how to select the patient. Yes, we have, Rachel.
Maybe can we test temporary on end for this section first, then we go to HA380. Then after we come back for the more detail on the priming, because we have one hospital doctor are very interested, and then we're going to maybe need to give them give him some information, and then we want to start the sales now lah. Okay, maybe later, or we come back to the priming section. I think that one will take time lah. Oh, okay. So can we go to next HA330 first? 380?
Okay,
Yes.
no problem.
Yeah. After we come back to section for the priming. Yeah. Okay. Thanks.
Okay.
So for this one, I'm just going to briefly give you guys an introduction of HA380 in the areas of sepsis and septic shock. So maybe next session I can go by details. I can go in details. The use of HA380 in ICU areas. So what is sepsis? So according to the sepsis 3.0, sepsis is the patient's response to the infection is dysfunctional and resulting in life-threatening organ damage. So the patients are receiving are contacting bacteria or virus, and usually patients' response to the infection, their immune system is functional and it is regular. But when they have too much bacteria and too much endotoxins, their immune systems are becoming dysfunction, and they can react to the infection normally, and further they can resulting in the life-threatening organ damage like organ failure. They have a rapid drop in the blood pressure, and they have start feeling unconscious, and they have start feeling high fever, and all the cytokines and all the inflammatory mediators are coming out of the cells into the bloodstreams, and this is the sepsis. And if we cannot treat sepsis immediately or on time, it can result in the septic shock, which is a deadly disease. So as you can see, in patients with sepsis, they have pro-inflammatory cytokines like interleukin-1, interleukin-6, interleukin-8, and also the TNF-alpha. Those are the mediators that triggers inflammation. So they are the bad cytokines. And on the other hand, we have good cytokines. We have cytokines that fight back with the pro-inflammatory cytokines. We have anti-inflammatory cytokines like interleukin-4, interleukin-10. So in patients with sepsis, they have excessive pro-inflammatory cytokines in their bloodstreams, leading to the microcirculation distributions they have, leading to the cellular injury they might have, leading to blood coagulation dysfunctions they have, which is building the blood clot. So all these mechanisms can leading to have a liver kidney failure, and they might have experiencing high fever. They might experiencing hypertension. They might experiencing hypotension after they experiencing all of these symptoms. So under these circumstances, we are aiming to remove pro-inflammatory cytokines to further stop patients from developing sepsis or septic shock. So for this stage, we are aiming to remove pro-inflammatory cytokines. We are targeting interleukin 6, we are targeting interleukin 8, we are targeting the TNF alpha. So those are the pro-inflammatory cytokines. So this is the main concept that we are using. So how we identify the right patients for HA380 in septic? So of course, patients with sepsis or septic shock, according to the international consensus definition. All patients who are not diagnosed by the doctors can also use our treatments once their interleukin 6 is bigger than 500, or their TNF alpha is bigger than 100, or their CRP is bigger than 100, which is C-reactive protein. It's also a biomarker of infection. And sometimes patients who are experiencing sepsis can result in the septic shock. So in these situations, at least one organ dysfunction appear, or the use of high dose vasopressor. So the vasopressor is a medication that used to evaluate patients' blood pressure. So in early stage, sepsis patients might experiencing hypertension. So their blood pressures can go up high to 200 mmHg at the early stage. But once their infection is not controlled by the medications and by the proper treatments, their blood pressure can drop very rapidly, and can be dropped to 40 to 60, which is crucial for patients. So therefore, the doctors sometimes use high dose vasopressor to up patients' blood pressure. So this is also a very important indicators for sepsis or septic patients. So for the protocol, we recommend use the cartridge twice in the first 24 hours of diagnosis of sepsis or septic shock. So once doctors diagnose the patient has sepsis or has septic shock, we recommend them to use the cartridge immediately in the first 24 hours. And we recommend use twice. So each cartridge is recommended to be used for 6 to 8 hours. So you guys might wonder that why this is 6 to 8 hours, because for patients in ICU, they sometimes most likely they will receive CRRT. CRRT might last for 12 to 24 hours. So in combined with CRRT, we recommend this a little bit longer to 6 to 8 hours. And the interval time between the two treatment can be 6 to 8 hours. So which means the first treatment finished, and we need to say another 4 to 8 hours for the next treatment to be started. So after the first 24 hours, we can use one cartridge per day until the symptom improve or until patients has no longer indications for the HA therapy. And here is a one case control study that shows that patients receive CRRT combined with our HA380 or HA330 treatment. They have a better 28 days survival rate, which means that they have more patients survive after receiving treatments, and patients overall health outcomes are also better than who are receiving only HA treatments. So their SOFA scores, their shock index, their oxygenagens index are also better compared to the single treatment. So this is just a brief introduction of what is HA380 and HA330 and how they utilize in patients with sepsis and septic shock. So if you guys have any questions.
Patrick, so the
Yes.
what is it called? The inside housing that one? 那一颗颗的 the
Resin.
resin. Ah,
Resin.
the
Yeah, yeah.
resin, is it same as 130? Or
Not the same.
So
Not the same.
not the same, but we use the same material. We use the same technique, but the surface area and the pore size is different. So we adjust the surface area. The surface area of the resin is larger than the HA130, because for the ICU patients, we need to remove the toxins in very short time. So we advance the surface area and we advance the pore size. So it enable rapid removing of the toxins.
okay, thank you.
Patrick, can I know that what's the difference between HA330 and HA380? Because your case studies is showing using HA330.
Yes. So right now I'm not really sure like in Malaysia, but in other.
Let me answer these questions. Okay.
Okay.
Okay. Because this slides is our basic slides. So normally right now HA180 we are using in ICU and also in CBP. And then right now in Europe, some countries like in Spain and Italy, we have some ongoing trials. So right now all the clinical trial we study in HA180. So right now, as you can see, the new papers, and then the conclusion is coming with HA180. And then 130 step by step, we will not invest in the clinical trial, and also we see that HA180 have better outcomes for the patient. As you can see, the vaccine volume is bigger, and then more scientific papers, and then also have a good outcome, including in CBP. So HA380 is our right now our key products promoting in CVP and in ICU. So I think for as you can sub, but 330 is how to say it is like the is our we have some papers, but many papers is from 5 years ago. Currently, the new papers all comes from 380. So step by step, we all the paper will come with HA380.
Okay, thank you.
So mostly in ICU, we need to choose some to identify what disease what is our opportunities. Maybe the first one is sepsis, septic shock. Another is pancreatitis. The number three maybe is hyperpremia or the some like after the earthquake, they may suffer some how to say Patrick 恒温肌溶解那个有没有那个介绍给他们？pancreatitis 对 wider bone lysis. So this one is I remember 2 years ago there's an earthquake happens in Turkey. So the citizen they have some muscle injury, so they will face this disease. So this is also our major indication for you can use in ICU. So just now Patrick he introduced about the sepsis, and Patrick you can go ahead and then to introduce the rest of the indication, pancreatitis and also this indication.
Okay. I think in this slide is mainly about the lectures. So, okay. So for patients with so for acute pancreatitis, patients with acute pancreatitis, they often have excessive lipid levels, which means they have more fats in their body, leading to the infection of the pancreatitis. So for this one, some hospitals are using CVVH, and some hospitals are using the DFPP. So in this RCT studies, they are comparing the patients who are receiving CVVH compared to patients who are receiving the FPP. So the result is that patients who are using the CVVH plus PAPA, which means the plasma absorption, that is the same technique that we are using. We are only that we are absorb plasma and lipid and the fats. So the result shows that there is a shift and substantial reduction in the total cholesterol levels and also the low density lipoprotein. So the low density lipoprotein is a bad lipoprotein that we don't want them to stay in the patient's body. And also, additionally, there was a slightly increase in the high density lipoprotein. So the high density lipoprotein is what we call a good lipoprotein. So by using the product, we can see that there is a substantial. There is a significant drop in the overall lipid levels, and additionally, there is a slight increase in the good lipoproteins. And result 2 that shows that also there is a significantly reducing the cytokine levels, which means that this is also effective in the mediating the inflammatory response, and also the enhancing the liver and renal functions. And overall, they have better clinical outcomes compared to those who are not receiving the cartridge treatment. And for another, let me just one study per indication, I think. For this one, so while we are aiming to targeting remove the myoglobin. So the myoglobin is the molecule that results from the tissue damage. So once that patients are using too much muscle, or their muscles are damaged by the outside force, like by the by mechanical force, they will release a molecule called myoglobin. So in this case, we are aiming to remove myoglobin. So in this study, the results shows that myoglobin removal with a reduction rates between 41% and 50%. And also people who are undergoing CPB, there is also reduction in terms of myoglobin peak. So there is a overall of removal average removal rate of myoglobin is 380%. Also for and trauma, so patients who are experiencing trauma and also experiencing severe burn, they can also use this one, but this is 330. So maybe in the next session, I will organize some literatures that for HA380. So if you guys have any questions so far?
No.
No?
Yeah.
Okay. So I think so this slide is, yes.
Okay. This is the training for ICU, the basic training. And then back to just now, Rachel's questions. Here I can share my screen to share more details how to set up and priming for 130, and also how to select the patients. So Patrick, you can stop your sharing. My sign will be shared.
Okay.
Okay. Okay, can everyone see my slides?
Yes, can.
Okay. So that's how to set up for 130. So normally, as you can see, divided in two parts. First one is hybridization, and another is priming. So the first part is hybridization. As you can see, the heparin is 12,500 international unit injected into the cartridge. So put in the cartridge, injected in the cartridge, and then shake in 10 times. So left in the quarter half hour. So after the half hour, we will do the priming. So here we suggested 3 liters. So that means 3,000 ml of saline to flush it. And then you can use that's one normally you use in CBP. And then you use the saline to flush, and then use one face mask. Or you can, as just now Mr. Patrick mentioned, you can flush it using the machine to flush together with the dialyzer. So that is our normal setup and priming. It's very easy. Heparization, inject the heparin inside the cartridge. And then this one, the meaning is avoid the cutting, avoid the cutting, and also prevent some anticoagulation issue. So we make sure the heparin because as you can see in our cartridge has many vaccine. All the vaccine will heparization, so will prevent some indication for the clotting for the patient. After that, we priming. And then this is for the setup and priming. Another I would like to share about, as you can share some pictures to you. This one is for dialysis machines. You can see my screen, right? Okay. Before the dialyzer, just need one extension tube and connect the dialyzer. This is for CRT machine, and then CBP. And this is our expert consensus. So in here we have there's a Shanghai Medical Associations to make our HA130 the consensus. We have 9 communications. So 9 implications. The first one is the pruritus. So how to identify what kind of patient has pruritus. So here we have one score. Which one is the DUO DOS pruritus score or VA WAS score is bigger than 8. So our recommendation is once or twice every 2 weeks. And then the second one is sleep disorder. So we have another international criteria is the P-STEPN sleep quality index is bigger than 5. And then another, for example, maybe the doctors most interested in is the beta 2 microglobin. So beta 2 microglobin is larger than 30 microgram per liter. So that's our target patients. And also hypertension, refractory leg syndromes. So normally we will deliver this concept to the doctors. So let the doctor have the mindset and let the doctors to select the patients. And then I think for our, as I mentioned just now, for the beginning of our promotion stage, most easier to find the patient is first one is pruritus. So maybe we can provide this to find some pruritus patient and also some beta 2 microglobin or some hypertension. And then, yes, this is our general prescription. So normally, HA130 together with hemodialysis once a week. And then together with HTF or hemoabsorption. So suggestion and session duration is 4 hours. And blood flow is the same blood flow, 200 to 450 ml per minute. So any calculation you can use the low molecular weight heparin or vaccination in heparin, citric also can. So this is that's just how I mentioned the 9 indication: pruritus, hypertension, sleep disorder, refractory syndrome, and Let me check the other selling points. Oh, this is our some COE hospital in our overseas market. So this we know in the international medical institutions they have tried and also when they are using our products. So for example, IV in Italy. So this one is belongs to Professor Cardiovonco, our KOL. Switzerland and Greece. Also, which one is most famous in our Asia Pacific is NKF, National Kidney Foundation in Singapore. Right now they are using our products. Also in Philippines and Ecuador. So I think if you visit a doctor, some doctors they propose maybe they need to do the clinical trial or they are interested how is the safety or effective. So maybe you can sort this name to them. So one of many famous hospital is using our products. But if they still want to do some clinical research in some new indications, we are welcome to discuss. But I think the major indication or major patient, why not they are benefit for it already. So if they have the new area, we can discuss. But we don't need Malaysia to do the clinical trial again to prove that our product is work. I think our major we have already promoted this product in China 25 years already. 25 years already. So we have many great experience already. So why now like in Singapore, so every year we use 1,000 pieces, 130 already. So some patient they are doing this our absorption before they are, because as you know the diabetes divided in 5 days. ESRD divided in 5 days, the end of the diabetes, that means 5. So some patient they want to prevent their kidney injury or diabetes. They also have the buying power. So mostly they will doing before the ESRD 5 stage. So we also have that kind of the patients. Yes, another we have some new clinical another one is for RCT. In China, this 130 we have RCT papers, and then to effect it in middle and molecular weight and you will make pruritus. And then another most interesting area, which is focused on cardiovascular related mortality. So we have a 3 years follow-up pilot study in Vietnam. So the patient, I think the first one patient may focus on the pricing, another focus on the toxin clearance, how many percentage we can absorb. Another most advanced concept is the cardiovascular concept. So we also have this paper can support us, because right now, as I can see, this one is more popular, is very hit topic. Survival outcomes, and then we have the survival outcome tests to show this we have a better survival outcome after use our products. Cost effective, and then also last time in one doctor's asking our comparison compare with HDF and our hemoabsorption, we have calculated many aspects. We have a conclusion that actually the HDF, they need to buy the water, they need to buy the machine, they need to buy the water solution. So totally, we do we take the math. So finally, we found that hemoabsorption is more cost effective. It's a study from Italy. So right now we have one pilot study from Italy, also is doing the hemodialysis alone compare with the hemodialysis plus our 130. So right now we have this study. So as you can see, the some better to microglobin. And then that's our conclusion. So HA130 can remove fetal molecular and protein packed uremic toxins. So we have mostly we manage the patient's communication, because as you know, long-time dialysis, they may suffer the communications. So communication like the skin itching, malnutritions, inflammatory response, hypertension, renal opticianary, and cardiovascular disease. So each communication they related one biomarkers, PTH, leptin, CRP, and beta-2 microglobin, something like this. So that our final objective is improve their life quality and benefit the survival. So that is I want to share in this 130 ratio.
Okay. Any question from X-Core side?
Okay, we need to do our promotion now. Okay, that means okay, like for hospital normally, how are we going to promote? Okay, so there we have a patient. Okay, we have a doctor interested to try. Okay, so we need to decide pricing and then how much of quantity. Then based on the trying and then fix the price in package. I think it's more easier than just like go there and tell them one piece how much, right?
Yeah, that's what I think we will going to discuss when we meet later.
Yeah.
Yeah.
After maybe we discuss with Eric together then how's our idea, then the promoting what to call marketing strategy, this and that. Yeah. Okay, so my targeted HA130 is normal. Okay, hospital we will status we have government hospital, we have private hospital, we have private dialysis center. Okay, so like just now you say, okay, in Singapore only NCAP using, right?
We also have some private dialysis chain they're using, like in AKDC, Asia Kidney
Foundation, yeah.
AKDC, and also some KDC, also kidney. I forgot the full name. So normally around 6 dialysis centers they are using our products. So NKF is the biggest, and then the rest of it is mostly they are private. So some patients they have the private insurance, they can claim the insurance. So that's our target patients.
Our private insurance, I'm not sure Malaysia, because we this is new product for us. Okay, because dialysis in Malaysia more than 40 years. Okay, so private insurance cover, even though government insurance also cover. Okay, but the first is we need to have some hospital to try our product. Okay, because we need referral. Okay, so number one, I say, so government hospital, we create some budget okay, to start on trying or on buying or what. Okay, so second now, because private hospital, one of the grand legal doctor interested our product, so we're going to set our marketing strategy, then pricing and then quantity for him to move on. Okay, then the private dialysis center. Okay, so like say so mostly private dialysis center, they have some patient that have money. Okay, so we can request the patient to buy our product, put on the treatment. Okay, so and then after that, Malaysia we got another so we call, okay, because so it's a government insurance. Okay, so we need to have more of the what we call user. I'm using it, and then the product is good, and then we got a paper. Then we can maybe try that as the last stage. Go to the promote to the body. Yeah.
Yeah, I agree.
Mm-hmm. Okay, so I think product info, I think not much problem. Priming important, I think we more or less we know already. Only that because we need to do before half an hour the patient come in, because normally dialysis their started is they will insert the everything the dialyzer and the bird line, and then after that we do priming. Okay. Yeah. So if we need to extra out this one HA130, and then after that only can connect to our system, right? Is there any way we can start the priming in together with our dialyzer and bird line priming in the same time? Is it possible?
Priming in the same time. I think the hybridization just happening in the cartridge. At least you need to wait half hour, but priming you can do it in the same time.
Okay.
Yes.
Okay, I think never mind. We need to try first. Then after we will come back to you. Then how is the problem or what? Okay. So but so far I don't have any big issue. Okay. All right. Rachel, anything?
For product technical part, I don't have any issue, but I want the documents and then like the studies that you have presented so we can share it with the customers.
Okay.
Yeah. And like if you have like a flyer written out, like what is the recommendation for using HA130, HA380 in ICU, so you can send it to us also. And then also like if you have the flyer for patient selection, that one, please also share it to us so it's easier for us to present it to the doctors.
Yes.
Yeah.
Like the flyer, I will share it to you like this. Share my screen. There's our HA180 flyers. So our best practice in sepsis patients. So the patients, they start with our absorption when they meeting the criteria A, B, A or B or C. So the first criteria is that sepsis according to international consensus definition. So we may focus on some biomarkers, IL-6, IL-10, TNF-R. If they are larger than this criteria, we suggest it is our timing to start HA380. Another is at least one organ dysfunction or use a high dose vasopressor. So that's because normally for sepsis, also for COVID, the patient may suffer the cytokines. So how to prevent the cytokine? Can use our hemoabsorption to prevent the multi-organ failure. So this is our objective. Another one is associated with the AKI. So critical stage or higher, that's some criteria. And then also we have some regimen, how the prescription can use one or two in 24 hours. So after 24 hours, we can keep using one, and then the birth flow. I think that's what very clear, and then can give to the doctor. I think Rachel, you must read this, right? This one.
Yeah. This is okay. And then I want to ask one question. So in ICU, right? Because I'm not familiar with ICU kind of treatment and setup. So I want to check what like how do the doctors determine that the patient is going through this chronic thing. Can you share just now the
okay.
recommendation?
Okay.
Okay, so here stated if let's say IL-6 is more than blah blah blah, IL-10 is more than blah, blah, blah and TNF, right? But in ICU, will they have this result for this?
Yes, they
like
have. They have. They have
Because
because
as I understand, like in Malaysia, it's very difficult to get tests for IL-6, IL-10. Not sure about TNF and PCT.
at,
So
at
which
least at least because PCT is the gold standard for identify the sepsis. So since the PCT they have the improvement, means that sepsis have the improvement. PCT is the gold standard. So or you can focus on CRP. I think at least if the doctors he give the conclusion the patient suffer the sepsis, so they may they also follow the international criteria. So one or they found it one organ dysfunction. They have one organ dysfunction or can miss the requirement like this. So they will do the sepsis. Once the patient have the sepsis, and then to prevent the sepsis, normally we will link to the cytokine or prevent the acute kidney injury. So there's the timing to start our hemoabsorption. So no worry. I think the patient they have the criteria, and then we just remind the doctors and then let them accept our concept. Once starting CRRT, it is also the timing for us to start our hemoabsorption. So that's our strategy.
okay.
The doctors they know don't know it already. So the key point is how to let them accept. Together with, for example, Baxter, they have the Osiris filter. So Osiris actually they cannot absorb the cytokine, but they claim that they have the they claim that they can absorb the endotoxins. But we let them accept our concept and then can use our hemoabsorption to manage the AKI. So that's our target.
Okay.
Can I know more about the exclusion criteria, the active bleeding, last stage of the maximum toner? That means we cannot use for this patient, this kind of patient.
Huh?
I mean,
Sorry?
the doctors cannot use for this kind of patient, is it?
Discount? Oh.
For the exclusion criteria.
Yes. Exclusion. Yes.
Means if they have a very serious bleeding.
Yes.
Or the last stage of this tumor is not recommended, is it?
Yes. Correct.
Okay, so only these two criteria?
Yes, only two kinds of criteria.
Okay.
And then for 130 also we also have some criteria. Let me see.
And let me just weigh in here. So for pregnant patients or patients with child, we are not recommending as well.
Okay, noted.
Yeah.
What is the youngest age that can do this HA?
Oh, HA, I think for example, HA130, our suggested we calculate in the weight. I remember it's around 20 kilogram, 22 kilogram.
Below cannot do.
No,
22 kilogram.
大于 more than 22
You need to more
kilogram.
than 22 is considered is peak already.
Yeah, the volume for the HA380 is how much already? Yeah, the cartridge.
The volume for
The
HA1.
volume, yeah.
Okay, let me share. Okay, the total vaccine volume is 130, and total, including the water inside, total cartridge volume is 230 ml. The primary volume, yes, as you can see here.
So if the kids will they have overloaded if this volume go into the patient? It's about 200 ml go into the patient. My question clear. Sorry.
For the PTH, we have a specific mode which call is HA60. It's that's our smallest volume, especially for PTHs. Can use in CBP and also can use in ICU dialysis.
Okay.
So cytosol they don't have a PTH mode. Right now, only Japan we have a specific for children, HA60, and Rachel also have she has a registration already.
For HA60 can be used in ICU CRRT as well, and the minimum weight is 22 kg, or 22 kg is 380.
Yes.
I remember in CBP 60 is below 11 kg.
Yes.
So is it the same? Is it the same or?
Same.
Okay.
I think like this. So there's a very good question we discuss. So normally that's our supplier suggestion. So normally how to calculate in the way, because the main concern is the blood volume, the blood flow volume. If the catheter is too large and then the patient is small and then their volume of the body is very large, so maybe the patient they will suffer the blood pressure issue. So I think normally the doctor they will calculate how much the blood out and then how much blood in. So calculate. They will use some they will use some how to say the blood and then to inject it to calculate. So they do the calculation to ensure that is the balance. So and then can manage the blood pressure.
Okay. Got it.
Hello? Hello?
Yeah. Listen.
OK。所以刚才讨论那个问题啊，关于体重的问题，包括那个多少体重能用，其实跟这个医生的观念有关。如果那个体重太低的，其实也没关系。最重要那个医生他会用一些我们叫做白蛋白的东西打到那个透析管路那里，然后保持那个血液循环那里平衡，然后病人他本身出血量就会减少，相当于病人不用出太多血，但是那个管路那里已经有相当一部分的血液替代品去满足，然后我们的罐子也不会占用它的太多的血就可以了。一般只能这样用，但是我们提供的肯定是最保险的，就是我们建议的，比如说22公斤是最保险的。但是如果 没有，有时候那个病人是很小，但是很急需用我们的产品，医生他自己会计算，就大概这样的原则。包括我们上次以前在西班牙，包括在新加坡，我们做那个 CBB，有个病人有个婴儿也是用380，他刚出生而已，好像只有4公斤，四
哇
公斤，然后他也是用我们380，然
哇
后那个心外医生他会计算，计算出来他打那个白蛋白，打到那个 butt tube 那里，要把那个管路全部充满了。充满之后呢，就接到病人那里，相当于病人就不用自己付太多的血出来，这是安全的，但是要做数学题要做得准。医生他会算，他有个平衡理论，但我们是外行人，不是很懂。但是医生，你告诉他要计算，其实最重要是，因为他如果出血太多，他血压会下降，但是你保证那个血液计算好的，他血压没问题就没问题不存在的。其实这个大和小之间是我们厂家间肯定最保险，我们给的只是说你不用去加那个蛋白进去，我们给的 prescription，但是你一旦你自己医生去，相当于一个管路，这里少了，我们要加多一点，就这样子的一个基本原理就好了，
可以明白，
明白吗？
跟我们的那个
一
PICS
样的，
的那个 CRT 是一样的原理。
是的，是的，这是比较
对
严谨，但是我们介绍的肯定最简单，因为我们怕出事。但是我们很
对
多市场，包括新加坡用380做开胸手术，我们都可以用4公斤而已，刚出生的，而且
哦
对一样可以。心
，OK
外这么严重的，然后我们打 dialysis 安全很多，对，
OK，
安全很多。
所以有个说法就会，因为一般
有有有
上医生都会这样问，你最低
有
可以去到什么重量？
有，我要找资料，我记得有一页 PPT 讲这个。对，你们问这个问题很好，我们都有这个，因为很多医生也会问这个问题。其实这个东西当然要看市场策略。如果你觉得这个医院啊有可以发展这个儿童，比如说儿童很多，我们可以直接推 HA60，或怎么样，或者你看着来，或者有时候他很紧急，HA60让他用 HA380去算好那个量去做也可以，但是你要保质前后一致，对，这样子。不然你说又让计算它以后就规定有这个型号，又很高风险，就没有必要了。
应该也会根据这个价格
对，
吧，价格跟你那个
是的，
result 出来是怎么分别60跟那个
对
380。
对，没错。
For your information, 60 and 380, the price is the same.
嗯，
这样
Yeah.
result 是差很远吧？应该是那个 surface area 的问题。
Because the concept is the same. It's just that you use it in different type of body weight and the blood volume. So
Okay.
actually is
But I believe will
similar.
be
It's the same.
different in terms of the membrane surface size.
Maybe Eric, you can help on this.
OK，
Because based on our understanding, it's actually the same. So it's just that the difference is the volume, the blood
OK
volume and the cartridge volume.
OK，首先这个儿科的市场总体来讲是不大，然后呢，我们推这个 HA60最大的优势在于别的竞争对手，第一个没有，第二个的话呢，就是后面我们其实还有个产品是专门做 liver disease 的，就是 acute liver failure 这个东西，所以我们配备有 HA60的这个灌流器，还有我们这个 bilirubin，我们还有一款 filter 是专门吸附的 bilirubin，还有那个肝的东西，那个肝脏的东西，这个搭配起来我们叫儿童肝脏治疗，所以我们这个是搭配到一套。但是如果有时候医院它考虑到安全性啊各方面啊，那我们用不到380的话，包括你刚才提的是对，包括380那个surface area 啊，还有其他的 absorption 啊，这是正确。但是有时候它兼顾不了，它要很高安全性，比如说它比较保守一点，conservative 一点，那我们可以用这个HA60。但是像我刚才讲的，这是交给你们去判断了。但是我们始终无论他用380好，HA60好，我们保证他能够接受我们技术，然后他能够安全的去用就好了。但是我们希望是两套的话，针对不同医院有不同的策略去推，这样子就好。这是结合你们自己的情况啊。那有时候我们讲哦，你们这个没有 很危险，然后你告诉他可以这么算，可以这么算，那万一他不接受呢？接受我们至少有 HA60让他接受嘛。但是如果你不跟他讲这个东西，你又推 HA60，可能我们也丧失了一些 HA380的机会。所以这个就是一个基本的点。
OK，了解。
Sorry, because I have colleagues that do not understand Chinese, so maybe we just give a brief
Okay.
summary on what we have been discussing. So
Okay.
it's about the 60 HA60 and HA380 like why and when, right? So the 60 is about the choosing. 60 is about the patient's 对不对啊 Eric 我讲的
对。
Yeah, okay. So we classify two lah, okay, easier lah. So one is child, okay, children. One is adult, okay. So
Yes.
below 22 kg, we consider children, okay. So
Yeah.
children, because you don't have much of blood, okay. So how you take out the blood from the body, right? So we use small size, HA60, but
Yeah.
how many cases, okay, in Malaysia we call PIT case, okay. I think very very few, maybe less than 20 cases.
Oh.
Yeah, in a year, okay. So that's why we need to keep the stock for these cases or not. So we concentrate on HA380 for ICU or better lah.
Yeah. 但是这是我们的卖点，就是说 cytosol they don't have children size.
Yes, correct.
And then that's our feature. And also I think for the future our product side we also have the one product can do it in liver dialysis. So liver dialysis we also can propose this concept again. So HA60 we when we meet the doctor we can 我们可以保持一个就是开放的一个说法了，不然到时候
we can tell our user we got the product, okay, but because like I said liver cases for children, I think also very very less, because Malaysia got 2 hospital cover liver cases, liver transplant or what, okay. So one is PPUM Mata Yuan Malaysia, University Malaysia Hospital. The other one is Lion Hospital. I think children one, I can come back to you lah. So how many cases in Malaysia a year lah? If you're interested. Okay. Yeah.
Very small.
Yeah, very small. Yes, correct. Yeah.
I
Because
agree.
we do CRT line, we know. So our pit line, actually we every year we keep stock, then almost we need to throw, and then that's it. Forget it. Yeah.
Also it's very expensive because
Yes. Yes, of course. Yeah.
生产太贵了，太少订单了。
Yeah.
Okay, but just to let you all know that because we sell the HA60 to CBP, there is the need for this also. So we do keep some stocks. So
if you
come across any
PIT cases, they will refer to you.
I mean, this item is available. Not say refer to me. This item is available in Malaysia that can be used. Yeah.
Okay.
So
In IJM.
just now I recall back what we talk about is like the 22 kg and the 10 kg is about like what Mr. Lai and Eric says. So it's the patient weight. So if let's say in the PITS case, they want to use HA380, it can be done, but there's a lot of calculation on the blood and etc. that the doctor needs to be aware of. So so to make it simpler, we just promote HA60 for the pediatric and HA380 for the adult. Okay, the cutoff point is HA60 for pediatric patient, which is 11 kg and below, and the others all use 380 to make it simpler.
Yeah.
Okay.
Yes, correct. Very
My
clear.
my team.
Yeah. Good.
Very clear.
Okay, Eric, one more question. You haven't tried HA130 in CRT machine?
Not yet.
Not yet, okay. So, but basically can use, right?
Basically can use, but I
how the outcome only?
I don't have some data about this.
Okay.
I think the efficiency we don't have any data because we in my market we target in at least 380 or 330 using in
Okay.
ICU. 130, we calculate that the volume is suitable for dialysis only for ESRD, not for sepsis. Because sepsis, they have many cytokines. I think the volume is not enough to absorb. That's my suggestion.
Okay, can, no problem. We let the user to decide. Okay, can. Oh, all right, yeah. Anything else? I don't have any question. Okay.
Questions? I think next time if you need more specific training for how to connect the tubing, we can organize another one to give you the training how to connect the tubing and then everything. So this one is our first time to organize such a training, and then to introduce indications and also what is the our selling points. So next time we can organize another training, maybe online or on-site training, how to connect the tubing. So that's the final goal.
I need to discuss with Rachel later. We're going to send out one quotations with the doctors, clinics. So maybe do you have any any people can support us, site support?
Oh, what time? When is it?
Don't know yet.
Okay.
Yeah, but we'll come back to you. But okay. In case of, let's say, you want to do online priming or whatever, so I think prefer maybe we do one time in our customer place. It will be better lah. Correct or not?
Yes, sure.
Yeah.
Let me know in once, and then I can block my agenda, because I will ask my technical guy to come from China.
Okay, great. Yeah, thanks for your support. Yeah.
Yes.
Rachel,
Any questions, Rachel?
There's one question in the chat that you have not answered. Like, heard about like slug. What is
Slug. Patrick, any ideas about slug?
or just now or just now we hear wrongly?
Which
Did you?
I'm not really sure about what.
Slug.
Or just now you mentioned something else actually that we hear it wrongly.
What's the meaning of slug?
Is it an insect? Is it like a bug?
This question, I think, Doreen, maybe you can further explain. What did you hear? Maybe we hear it wrongly or something like that.
No, I think from Lai, he asked a question and then you say it's a good question. So I Googled it. Slug is something to do with cancer.
Cancer?
I don't know. It sounds like slug, but I don't know what is it. So I'm not sure. Never heard before, so that's why I asked.
So which mode? 130 or 380?
No, I don't know. It is something like when asking questions, someone asks a question that the HA130 can like something for slug, and then
No, that is SLAC, not slug.
SLAC.
Wait,
Slow
SLAC.
dialysis.
Yes.
Slow dialysis.
Oh, okay.
How to spell that?
SLED.
Okay. Because here the voice come out something like not very clear, so just wondering.
Yeah, time to change phone.
Oh, I use laptop.
Just kidding.
Laptop.
Okay, time to change laptop.
It's new one.
No, just kidding. Yeah, because there is more actually like that we mentioned like we discussed just now. HA130 is more for dialysis. Dialysis we got two, HD and HDF, and then the other one in the ICU they use dialysis machine we call SLAC. Okay, because that one is running more than 4 hours, can up to 20 hours, but cannot more than 24. More than 24, then we use CRT already. That means in ICU you will see two type of machine can do dialysis. Okay, SLAC machine and a CRT machine.
Yeah. Low
So-
thrust, high thrust online.
So the Jeffron machine is which one? Is which type, Eric?
Jeffron machine.
Jeffron
We
machine.
can cover all kind of machine. 都可以.
It's a treatment mode lah. Actually, not
As you can see here,
Yeah.
treatment mode, hemoperfusion, low thrust dialysis, high thrust dialysis, online HDF, IGS can also combine with our hemoabsorption. So after combine it, we can clear the protein toxins and also middle molecular weight. So all the answer will be yes, as you can see here.
But this one is in the renal dialysis or the ICU dialysis?
We know is similar with CRT, ICU, same. But
means that
this,
the machine is the same? Sorry, I
same.
do not know your...
It's not the same, but the CRT is the time is longer. This is short time.
Okay, so this particularly is for HA130 only.
130, yeah.
So it's
Yeah.
not, it's
Yeah.
not for 380. 380
No.
is very simple, straightforward, is CRRT. Am I
Yes.
right?
Yeah. Yes.
Okay. Thank you.
Yeah. Any questions?
No.
Okay.
Yeah.
Slack, not slack. Okay.
Okay.
If no
I
question,
think-
I think today training is the
We'll
first
end
time
here.
to give the training. We have more opportunity to organize this training. So as Mr. Lai he mentioned, maybe if you need on-site training, please let me know in advance. My side can arrange my colleague to come, and then
How soon can you arrange?
How
For
soon?
example, now I say we need. So like how soon your people can come?
how soon? I think at least 2 weeks before.
2 weeks.
2 weeks.
Okay.
2 weeks in advance, because sometimes, because maybe Sumesh, he will go to another countries. Maybe he's busy. So
Eric, maybe I will visit the hospital and then we will discuss with the doctors, okay? Because then after we get a date, then maybe we see we can match the date to come together or not. Oh, let's arrange our pressure. For us, easier, we just go to Grand Niggers, then talk to Dr. Fan, then because he's quite interested. I think that one should be no problem. After we come back to you, the date, then maybe 1 or 2 dates for you to select. Oh, yeah. Because we need fast. Yeah.
Okay.
Okay, anything else?
No?
Okay, yep.
Okay, thank you so much.
Thank you,
for
Eric.
attending.
Yeah,
Thank you for
Patrick.
giving the training. Thank you,
Thank
Patrick.
you.
Thank you, Eric. Thank you, Patrick.
Thank you.
Thank you.
Thank you,
Bye-bye.
Patrick. Thank you,
Thank
Mr.
you,
Lai.
Eric,
Thank you,
please
Rachel.
share the recorded
Okay.
training.